Hi, everybody. Oh, this is David Bland. I'm head of sales for Euclid Systems Corporation. And I want to thank you for joining us tonight for this webinar from Euclid Systems Corporation. We very much appreciate you taking time out of your busy schedule tonight to learn more about Euclid and Euclid Max and how we can help you implement proactive myopia management in your practice. I am joined tonight by my colleague, Dr. Jackson Lau. Jackson is the Clinical and Scientific Affairs Manager at Euclid Systems Corporation. He continues to see patients in an MD-OD practice in California, focusing on cornea, specialty contact lenses, and myopia management, as well as serving as an adjunct clinical faculty teaching fourth-year optometry students. As we begin our discussion tonight, please feel free to ask any questions throughout the webinar through the Q&A format, and then we'll answer those as many of them as we can at the end of tonight's webinar. So tonight's objectives are, there's really four main objectives that we hope that you'll walk away with. First, learn a little bit about Euclid and who we are and our history and how it applies to myopia management, because it is important, particularly when you understand that we got our start primarily in China, where myopia is epidemic, and most of our patients have been children. We'll also review clinical developments in understanding myopia and how to communicate this to your patients, really to the parents of your patients, so that they can make an informed decision. Understand the Euclid Ortho-K designs and the clinical applications, and then learn some tips for successfully incorporating Ortho-K into your practice. So why partner with us? We're a 26-year-old company focused on improving the lives of patients with myopia, and we're really dedicated to myopia management in Ortho-K. And I said earlier that we got an FDA approval in 2004. But we went straight to China and really concentrated on that market. And I think it was hugely beneficial, because with myopia in such epidemic proportion, it really allowed us to refine our algorithm for our design so that it's really successful when you're dealing with children and myopia management. Our lenses have been fit on over 2 million eyes around the world. We are a pioneer in receiving a lot of different government approvals. We approved by the FDA in 2004, as I said. We were approved in China by the China FDA in 2007, and we were the first U.S. Ortho-K lenses approved in Japan and Taiwan. And these are all Asian markets where myopia is epidemic, and I think that's what's really key about Euclid. That's where we really cut our teeth in those markets. And we're the first U.S. company to actually have a wholly owned Chinese subsidiary. And one thing that's not on this slide that I would like to add that I think is applicable is the Euclid Emerald is the #1 imported brand into China, which is the world's largest Ortho-K market. We're a global company. We sell and offer our products in over 15 countries around the world. And are very, very widely known in a number of these countries: Australia, China, Korea, Japan, as well as now in the US. So that's a little bit of an introduction and what we want to accomplish tonight. I'm going to turn it over at this point to my colleague, Dr. Jackson Lau.
Thank you very much, David. I want to begin tonight by asking the question, why are we worried about myopia? There are significant public health ramifications from this growing prevalence of myopia, and it's expected to become one of the leading causes of permanent blindness in the world. So you've probably heard already, within 30 years, by 2050, half of the world's population will become myopic, and 10% of those people will become high myopes. So it's pretty significant. As we can see from these alarming statistics, high myopia significantly increases the risk of more serious eye diseases compared to being emmetropes. 6 diopter myope is almost 850 times more likely to develop myopic macular degeneration, over 12 times more likely to develop retinal detachments, and 3 times more likely to develop open-angle glaucoma. So simply reducing the rates of myopia progression can have a significant positive impact on your patients. We'll focus the majority of our talk today on indications and fitting adjustments for Euclid designs, and I hope you gain a lot of useful tips and information to take back to your practice. In the past, And even when I first started practicing not too long ago, myopia was seen as simply a refractive error. Patients would be happy just correcting their blurred vision, which was a symptom of the condition, but not managing the condition itself. Today, with all the peer-reviewed research that currently exists, we now understand that this myopia problem is an axial length problem. So we have to manage this excessive axial elongation of patients so that we can reduce their risk of serious eye conditions throughout adulthood. So the longer the eye, the higher the chance of serious eye diseases such as myopic macular degeneration, retinal detachments, cataract, glaucoma. And it's important to understand that this abnormal eye growth can only be managed during the growth years. And once we reach adulthood, there's no reversing it. So the great news is that we have all these tools in our toolbox to manage our patients. I'm not going to spend a lot of time on each individual topic, but we'll be focusing our myopia management talk using Ortho-K. Ortho-K as the main focus is one of the most utilized and studied methods for providing clear, device-free vision for your patients. And one of the main advantages is that it's a strictly home-based system where all the cleaning, insertion, removal can be done under the supervision of the parents. So without any major worry of loss or breakage at school or outdoors. So it's a wonderful tool for your patients. One important topic these days is the idea of treatment zone sizes and the question of whether or not we're simply correcting myopia or whether we're doing something for myopia management. And when Ortho-K was first developed, a couple of decades ago, it was intended for adults as an alternative to refractive surgery. The goal was to provide the best possible vision. So particularly in nighttime vision, when the pupils would dilate, we would want something like this left-hand image where we see a fairly large treatment zone that was intended to reduce the amount of aberration and glares and halos for the patient. And this may be what we want for a non-progressive, older or adult myope. Now, the image you see on the right is through the use of our Euclid algorithms that we now use for progressive myopes in children to create these smaller treatment zones. So the idea is to potentially limit the axial elongation by pushing as much plus through the pupil and altering that retinal defocus and higher order aberrations, which are the prevailing theories on how Ortho-K works these days. So children are not typically driving at night. They have a much easier adaptation to aberrations, and they need good enough vision in their digital environment these days, which is typically up close. So in fact, I often set expectations for my patients and parents that if they notice these aberrations and glare, it's actually a good sign that the treatment's working and it's intended to give them their maximum effect. Here are the different Ortho-K design systems, as many practitioners may develop their own preferences for what works in their practice. I would consider empirical fitting, which is what we do at Euclid, to be the easiest method, as there's minimal startup costs. It's straightforward through the use of our consultants. The first lens you put on the patient's eye is likely going to be your last lens 87% of the time. There's no need to spend a lot of chair time or staff time putting on trial lenses and sanitizing those lenses and organizing the lenses afterwards. So it really reduces the barriers that make it difficult for practitioners to get started. For many years, I was using computer and topography-based designs, and obviously there are startup costs with software and hardware, but for very complicated prescriptions or eye shapes, they may benefit from this software where the lens is based on the topographies. But I'd have to say my greatest struggle was the steep learning curve, having to spend many hours watching videos to learn the basic designs and many more hours figuring out how to manipulate and troubleshoot those designs. So the fitting support was often difficult, and I'd spend hours after clinic designing lenses. So this just became a bit impractical for my practice. And so that's where with the empirical process, I think, I'd have my patient parameters sent over to the company within minutes, and I could move on to other things in my busy day. A lot of practitioners in school, they've also learned about fitting sets and inventory. And particularly given the current COVID environment, we may not want to be, using reusable lenses or trial lenses and cleaning those lenses, all that extra handling during this global pandemic, especially as we move forward. Empirical fitting processes are becoming very popular. So that's what we'll be focusing our topic on today. A little bit of detail on one of the best features of Euclid, which is that simple, easy to use 3-factor fitting. This empirical design process has been developed over 20 years of experience. And based on studies we performed, we found that we have a first fit success of 87%. And for cases that don't work within one exchange, you're likely up to a 95% success rate with one exchange. So this really helps save chair time and doctor time. At the initial consultation, you'll need 3 critical measurements. Your refractions going to help determine their vision potential and the amount of treatment we're targeting. Your K readings can be obtained either manually or simulated from topography. And that helps you to determine the base curve and helps us select the best candidates who are likely to be successful. And then lastly, your HVID, or horizontal visible iris diameter, that helps us calculate the proper lens diameter to make sure we're not landing on or potentially damaging those limbal stem cells. I want to emphasize that Ortho-K fundamentally does not mechanically or physically force the cornea to become flatter. What's actually happening is that posterior surface of the lens has been mathematically calculated to apply these hydraulic forces to reshape those surface epithelial cells, either by compression in the center of the cornea or thickening in the mid-peripheral cornea. So this allows us to temporarily reduce daytime myopia up to 5 diopters by wearing these lenses nightly. And then we assess the patient's symptoms, their visual acuities, and perform serial corneal topographies to gauge the success of their treatment. Euclid's design is a class 3 medical device, unlike many daily wear GP lenses or soft contact lenses. So therefore, we're pretty carefully regulated by the FDA and stay within the approved parameters. There's much stricter control of our products and manufacturing. So our approval is up to a -5 diopter for myopia. What this means is that there's only been clinical studies on the safety and efficacy in patients up to this -5, and our algorithm would work best in this low to moderate myopia group. The design is approved for with the rule of astigmatism up to 1.5 diopters, and against the rule of astigmatism up to a 3/4 diopter. And while the eccentricity, Ks, and corneal diameter are not necessarily exact limitations, attempting Ortho-K on these patients outside of these ranges may be difficult. So especially if you're starting off doing Ortho-K, I'd recommend you start with these easier to moderate cases to gain some proficiency. But if you happen to have any potential candidates that fall outside of these ranges and you really want to get started, I wouldn't hesitate to give our consultants a call to really discuss what kind of adjustments we can make and see if we can give you the best chance of success. So let's start by describing the standard Euclid Ortho-K design. It's a multi-curve design with pretty easily understood lens parameters. You'll find that many patients will achieve the best success with the standard 10.6 overall diameter, although larger or smaller options are available as well. The optic zone diameter on the back surface starts at 6.2 millimeters, and this was designed to be large enough for most corneas, but it can be modified based on your patient's needs. And importantly, keep in mind that the base curve, radius, and optic zone does not function in the same way as a typical daily wear corneal GP, in that it does not impact the fit of the lens. So instead, it's calculated to give the target power based on your refraction. And the next curve further out is the reverse curve, which is typically steeper than the base curve, and is the basis of what we call our reverse geometry design. This is the main mechanism which allows for that manipulation of the sagittal depth and helps us impact the position and size of the treatment zone. The next outer 2 fitting curves are what we call the alignment curves. And as the name implies, it aligns almost tangent to the surface of the cornea. They fall about the 8 millimeter chord, and these curves really aid in the positioning of the lens and are designed to closely interact with that mid-peripheral cornea. And as in any GP lens, that final outer peripheral curve provides that subtle edge lift, allowing for tear exchange in that open eye state, and really helps with patient comfort. In the center is that base curve here. So this is just another diagram. And again, this controls the power of your target correction. And although it does not show significant fluorescein, keep in mind that there should be a subtle tear layer of around 10 microns or so that's not visible to the human eye under the slit lamp. Beyond that is the reverse curve and the alignment curves, which are critical for controlling the sagittal height and fitting of the lens. And again, the outermost curve is that peripheral edge ring. All these curves are adjustable. So as you get more comfortable with our lens design, you can talk to our consultants and describe the fitting characteristics. And I really find it helpful when you're able to provide photos and videos, whether you have a dedicated camera from your slit lamp or even on your iPhone camera, that really helps in conjunction to any kind of topographical data that you can provide. So while topographies are not necessarily 100% required for the initial lens selection, it is very helpful for the ongoing treatment analysis. So the reason is that the eyes are performing under a closed eye environment. So the only really way to truly assess how the lens is fitting while the eyes are closed is through topographies. The pre-treatment baseline maps help you identify the shape, the astigmatism profile, eccentricity, pupil size, corneal size, and I recommend starting off with the axial maps. Oftentimes, I really think it's important to adjust the scale, because if you have too wide of a range in your scale, you won't be able to see many of the important details of the cornea. On follow-up visits, I recommend using tangential maps so that you can track the corneal shape changes and location of your treatment. And here we see a difference map where we can see a comparison between the baseline map in this top left here, comparing to today's treatment in this bottom left corner. And this allows you to visualize the changes that you've induced and helps troubleshooting for any kind of necessary lens adjustments. I want to highlight the left topography here. So in this example, both these topographies show corneas with about 1.5 diopters of astigmatism. But on this left topography, we can see that almost all of it is centralized or apical. And because the Ortho-K lens lands out at here at this 8mm chord that's outside of this astigmatism area, this cornea may do fine with just a spherical design. Now, conversely, if we look at this right topography, the astigmatism extends all the way from the limbus to the limbus. And in order to create that hydraulic fluid force 360 degrees around, you really need a toric design to help with proper treatment and centration. So don't hesitate to ask our consultants whenever you have questions about this. A toric design should be considered when there's greater than 25 or 30 microns of corneal elevation difference between the primary meridians at that 8mm chord. So this is what allows the hydraulic forces to work properly in that semi-sealed environment. And in other instances, a toric design may also help improve fit and decentration when the usual design changes are not successful. Limbus to limbus astigmatism is also a key indicator that you may need a toric design. And keep in mind, toric Ortho-K is not to necessarily treat any kind of refractive astigmatism. It's mainly to help with the fit and the centration of the lens. Here we see the Euclid toric standard curve widths. The overall design similarly uses the Euclid's proprietary curves to maximize both myopia reduction and lens centration. And note that every 15 microns of corneal elevation difference is equivalent to about 1/2 diopter of lens toricity in the design. And one important tip is to make sure you try to use the least amount of toricity needed to achieve your fit and centration goals, as using too much toricity in the lens design can lead to tight fitting lenses. Here we see a graphic of a side tear profile of a spherical lens on a toric cornea. And on the left, we see that the horizontal meridian is closely aligned in the alignment curves. So we'll see that there's not much fluorescein at that 8mm chord area. In this with the rule cornea, on the right image, we see that the vertical meridians are not well aligned. And that allows this really elevated fluorescein pattern here in the side profile. And this will likely lead to inadequate treatment or lens decentration because you can't get that 360-degree seal. Now, if we were to redesign that lens to become a toric lens on this toric cornea, we see that now we have the proper alignment in both the horizontal meridian and in this vertical meridian. And this will allow you to have a much better fit and the treatment to work a bit more properly. So our innovation at Euclid continues to improve and keep us at the forefront of technology. Euclid Emerald's Ophrofocon A materials been offered over 25 years and has great proven performance. Euclid now has exclusive approval for the overnight Ortho-K material in the Contimac Tisofocon A, which is Euclid Max. This is a hyper DK material, which is currently one of the highest in the US for Ortho-K. This can give practitioners a lot of comfort in knowing that they're providing the latest advancements in safety and performance for their patients. Generally, I think all practitioners would agree that more oxygen is better, especially in a closed eye environment overnight. We have advantages when we have higher DK materials that we potentially can reduce the corneal edema and reduce risk of infections by using a higher DK material based on some studies. And as some of the more seasoned practitioners on this meeting may recall, the reason it's historically been more difficult to use these high DK materials in the past was because there used to be more compromise with wettability and depositing and poor lens performance such as flexure and breakage whenever we have the high DK materials. This all really changed with the introduction of Euclid Max, which really allowed us to maintain the balance of all these high DK properties in addition to all those other properties we want in a lens material. So firstly, it utilizes the same Euclid design algorithm that helps us achieve this 87% first fit success rate. Secondly, it offers that great wettability and deposit resistance that's built into the material without any kind of surface treatment. So this really helps our patients maintain, good wettability and comfort over time. Again, we have this, best in class 180 DK material, highest of any US overnight Ortho-K brand. And lastly, the lens is optimized to have great stability, so has the potential to minimize any kind of flexure, warpage, and scratches and chips. And here are the studies of some of the peer-reviewed research that utilize higher DK materials. And this is where they found that not only did it allow patients to get better health and physiological advantages, but they also potentially experienced improved clinical outcomes. And the theory behind that was that because the epithelial cells are experiencing less edema with these higher DK materials, faster shape changes could occur. And anecdotally, I've heard that from a lot of our patients who've been using this material over the past year or so. And from an infection standpoint, there are numerous studies suggesting higher DK materials in general with contact lenses can reduce the risk of infections, which is something that we're always wary about. Discussing some of the individual visits, your dispensing visit is where you teach the patient, oftentimes the parents as well, all the proper techniques. You or a specially trained staff member should spend a good amount of time making sure your patient's comfortable with the entire process. Because the worst thing you can have happen is have the patient call you on the emergency line late in the evening if there's any issues. So I recommend you specifically recommend one care product system to your patients so that they know exactly what product to look for. They go to the store, they're going to see lots of different solutions, lots of different options, and become overwhelmed. So a lot of offices offer a complete package that can be even sold in their own practice to make sure the patient's using the proper products. I always recommend pre-printed instructions as they're very, very helpful to make sure the patients follow the instructions carefully. And even having these youngsters sign that they understand all the techniques and care regimen really gives them a sense of ownership and responsibility for their eyes. Depending on the practitioner, fluorescein patterns at the suspense visit can give you a gross assessment of the lens fitting relationship. And whenever you're doing this assessment, I recommend starting with the smallest amount possible so that the cornea is not flooded and obscured with all the fluorescein, so you can really look at the details of that fluorescein pattern. And one additional tip I usually give to new doctors is try to have the patient start their Ortho-K treatment on either a Thursday or Friday night, so that by the time they go through the weekend, their vision stabilizes over Saturday, Sunday. By Monday, their vision will be clear enough so that they really don't need any correction for schoolwork. Your first day follow-up visit is usually done in the morning. I usually like it first thing in the morning at 8 a.m. so you can see the overall impact of the overnight wear. And recently, there's been an evolution in the teachings of whether or not it's really important that the patient comes in wearing the lenses or not. I'd say for beginning Ortho-K fitters, I think it's a great practice to continue to have them coming in wearing the lenses on that one-day follow-up. This way you can spot things such as lens binding or other issues of corneal staining that if you were to have them remove the lenses first thing in the morning, it may not be evident as easily, especially if you're a beginning fitter. It's important to remind patients to always bring in their lenses. That way you can really assess the cleanliness and the fitting relationship of the lens if there's any kind of troubleshooting issues that arise. But the really wow moment that comes is when the patient comes in and once they have their lenses measured, you take out the lenses and you measure their uncorrected vision. And we see this dramatic improvement at that one-day follow-up. And the parents, the child will be really impressed at that stage. After that moment, I usually will check the corneal health carefully before seeing, perform your one-day topographies, and then every single visit, I like to review all your application and removal and care system steps. Some of your higher myopes may need to supplement their vision, particularly in the first couple days. So the easiest thing they can use is either an older pair of glasses or some soft lenses that you can dispense in the office. There's even some adjustable focus glasses called AdLens that they can purchase through Amazon. And it's important to tell the patients and their parents that different corneas mold at different speeds. So don't try to rush any kind of results. If you see that their treatment is between 2025, 2030, eventually they don't always have to achieve 2020, usually within the first couple of days. That's usually a really great result already. And so I usually recommend that you don't want to make any changes until at least usually the 2-week mark or so, because I found that many changes can occur slowly over time. Different corneas can mold differently at different speeds. So always want to recommend usually at least 2 weeks of wear time, and after 2 consecutive visits where you see consistent results before you try to make any kind of lens modifications. That'll really save you chair time and also make sure that you're not making unnecessary lens modifications. As a reminder, I always typically use the tangential maps at the follow-up visits so that you can see more detailed corneal changes. You can see the treatment zone sizes, and you can look at the location of your treatment more carefully. Depending on your experience and comfort level, you can tailor the follow-up schedules depending on whether the patient is a moderately progressing myope or a slowly progressing myope. Your first month is almost like a post-operative schedule. You have the 1 day, you have the 1 to 2 week follow-up, the 1 month follow-up. But after that, if they're really rapid progressive myope, I may want to follow them more closely and follow them every 3 to 4 months. And conversely, if I have older myope or an adult patient who's attempting Ortho-K, I may only need to see them every 6 months or every 12 months if I have really good trust in their care system and cleaning. At the first day follow-up and at all the future follow-ups, I usually recommend that you schedule those appointments at the end of the day. That way you can see how their treatment's holding up compared to the morning time. And you basically do the same steps: check the vision, corneal health, look at topography, and always review the care. Always remind parents that the uncorrected vision is a fluid process. So depending on how the child slept that night, depending on if the eyes are dry, it can cause reduced vision. So as long as the vision's between 2030, 2025, 2020, and you don't see any kind of corneal health issues, I usually reassure the patients and parents that they're doing well. The uncorrected vision is not the ultimate measure of success. As long as the topography pattern is showing this red ring forming, their axial length is becoming stabilized, that's what's important for the success of myopia management. Here's a brief review of the major characteristics we look at in the fluorescein patterns. So the first thing we look for is centration typically. Again, the topography is usually more accurate in assessing true centration, but the fluorescein patterns can still guide you in this process. I usually like to remove the upper lids and lower lids out of the way so that you can really check the centration accurately. Here we see this central treatment zone area. It's usually about 3 to 4 millimeters in width. And beyond that, we have the mid-peripheral steepening here and the alignment curves. And remember, it's important to see this fluorescein ring pattern 360 degrees around in order for that fluid hydrostatic fluid force to work properly. And then the last picture shows that peripheral curve where we want that tear exchange to occur. And this really impacts comfort in a lot of patients. So sometimes you may not see a significant ring, and other times you may notice that this peripheral edge ring is noticeable. This perfect bullseye pattern on the left is typically what you've studied and seen in textbooks or in lectures, but you may not always achieve that. So what happens when you hit a road bump and you experience a less than ideal fit? So here are some examples of some common issues you might experience: central island, superior inferior decentration, or lateral decentration. Starting with central islands, these typically are due to lenses that are too much sagittal height. So as you can see in this fluorescein pattern here, we see that the central treatment zone area has almost excessive apical clearance appearance, too much green dye here. So ultimately, you can't really see the point where that reverse curve starts. So ultimately, if you see this early on in treatment, this little area of steepening, it's important to not overreact right away. I usually, again, like I said earlier, like to wait at least the 1 to 2 week mark and confirm that there's no staining and confirm that this central island remains. And if it does, and the patient's still seeing poorly, the next step is to reduce the sagittal height by flattening those reverse curves in order to improve this central island. As far as inferior decentration, you may see something called a frowny face appearance on the topographies. And this is usually due to the alignment curves and the overall lens system having too much sagittal height as well. And so therefore, you may need to flatten those alignment curves so that you can recenter the lens a little bit more superiorly. And sometimes if that doesn't work, you may need to consider a toric design because there may be a misalignment in those primary meridians between those corneal elevation differences. Converse to the frowning face, we have a smiley face appearance, which occurs in superior decentration cases. And this is due to the opposite, where there's inadequate sagittal height. And notice that there's some portion of this treatment entering into that pupil area. So this patient may have fairly poor refractive endpoint. They may experience symptoms such as glare and halos, especially in dim light conditions. So opposite to the inferior decentration, you would need to increase the sagittal height so that we can steepen those alignment curves to reposition the lens a little bit more inferiorly and centrally to the cornea. Lateral decentration is usually caused, in my experience, by not having an adequate enough sized lens, meaning your lens is likely too small for that cornea. So if possible, you want to increase the lens diameter whenever you experience lateral decentration. With any GPs, and particularly with Euclid, you want to make those diameter changes of about 0.4 millimeters or more in order to make a clinically significant change. And once you make that change, you want to make sure that the patient's corneal size is large enough and that you're not impinging on those limbal stem cells. Whereas the previous fit modifications adjusted parameters such as reverse curve, alignment curves, diameters, any kind of overcorrection or undercorrection usually needs to be resolved by changing the base curve, which is what impacts the target power. And as always, if you suspect there's any kind of overcorrection or undercorrection, again, I usually like to make sure it's consistent over at least 2 visits and at least after 2 weeks of wear before I like to make those changes. Here are some final tips for your Ortho-K fits. Common question or issue that comes up is, what do we do with any kind of corneal staining? Keep in mind that the research shows the higher likelihood of corneal staining in higher myopes. So I generally advise you to be cautious and follow those patients more closely whenever you're dealing with a higher myope. If the staining's mild, they usually will resolve a couple hours after lens removal. So I always like to verify what kind of drops or solutions the patient's using, examine the lenses for any kind of buildup of proteins or depositing, and make sure that majority of my patients are using hydrogen peroxide-based system, but if the staining resolves, then I don't need to make any adjustments. However, if I have persistent staining or any kind of abrasions or coalesced staining that likely is due to a lens that's too flat or has inadequate sagittal height, then that's when I would have to make some modifications to steepen those reverse curves to increase the sagittal height and improve the fit of the lens. And sometimes these patients, you may need to temporarily discontinue wear for a couple nights, maybe even use some antibiotics for prevention of any kind of infections. And then once they're fully healed, restart the process, and you may need to, again, increase the sagittal height of that system before restarting for those more serious abrasions or staining cases. Lastly, I want to walk you through the labels, because this is oftentimes very detailed and a little bit confusing the first time you see it. We have to be very careful with our labeling because we, again, are a class 3 medical device. So on the left here, we see this is the label that you'll get that's wrapped around your lens case and has all the lens parameters that you'll want to know. The outer package of your, the outer packaging will have this label that's shown here in the middle. And below that here, we see that we provide you a return label that's inside the packaging. So if there's any reason you need to return a lens or exchange a lens, you can use that return label. And the bottom part is a record label, which a lot of practitioners have told me has been really helpful if they actually use paper charts. Somehow they can just stick this right in their notes, and that way they can quickly reference the details of their lens order. Looking at the details more carefully, we have the lens material here in color at the top. The material lot number is a tracking mechanism for us to track basically every piece of plastic we've ever manufactured. We have the patient information here. We have all the parameters that our algorithm has created, such as power, diameter, center thickness. You'll see a unique number, this ESC laser mark number etched into every lens that we make. So this will really allow you to verify and match the lens to the patient, because a lot of times you may get patients that come either from overseas or from out of state, and they may be wearing a Euclid lens, or you may have a patient who has multiple siblings wearing Ortho-K, and this way you'll know exactly which lens, and if there are any swapped lenses, you'll be able to figure it out easily. You'll see this manufacturing date here. All right, expiration dates. We have our barcode, which is a device identifier used for tracking purposes, number of lenses ordered, and all the lenses in the US are shipped in Boston Simplest solution. So this way you can identify the lot number as well. Be sure to reach out to our consultation team. They're experts at this field, and they'll guide you through every step of the way through the ordering process. They're available for calls every day until 8 p.m. Eastern, and here's their contact information. Also remember that Euclid offers many tools to help communicate the benefits of myopia management, particularly with Ortho-K. In addition to patient brochures, you can receive copies of our comprehensive supportive materials, such as in-office videos teaching basic lens fitting, insertion and removal, training videos, as well as troubleshooting lens fits. And contact your local sales reps if you want to reach out if you want to have any these kind of resources. And lastly, soon we'll be launching My Euclid. It's a cloud-based platform to help drive your practice efficiency and optimize those Euclid fits. It's aimed to create a really flexible interface for our simple 3-factor fitting, and has really great tools such as order verification and lens tracking systems. Here we see the 3-factor fitting. We see optional areas where you can, as you become more proficient with Ortho-K fitting, you'll be able to make additional advanced modifications. And there'll be sections to upload your topographies for our consultation team to review. And for your staff, you'll be able to track all your lenses and progress of your orders. And this will hopefully become a great tool that should be released in the upcoming months, so that you can really get started with Euclid fitting and become a really good fitter over the years. And so with that, I will ask if David can bring back his video. I'll turn this back over to David so he can tell you a little bit more about the
There's my ugly mug. So listen, thanks, Jackson. That was really a really great overview of Euclid and the Euclid, Euclid Max and our products. Very quickly, before we get into the Q&A, and while I'm wrapping things up, don't hesitate to feed us some questions in the chat or in the Q&A. If you think of them. We've already gotten a few, but don't forget, if you haven't already done so, take advantage of your complimentary pair. Euclid offers once you certify and open an account, the first pair is complimentary, the first fit to help you get through the system. And I think we've really added to that. We have Christy Yee, who's our practice implementation specialist, and she works with our sales team and with the practices. She started the entire myopia management clinic at Park Nicollet, so she really knows what it's like when you don't have anything going and you want to get it started. And she's really helpful in taking it from 0 to 60 for you. So as part of attending tonight's webinar, you also will get a complimentary consultation with Christy along with the free pair. And Dan and Karen are two salespeople. Dan, you probably know, covers the Eastern U.S. and Karen is in the West, and they will be reaching out to you with a special code to be able to take advantage of this. So I think, I think that was it. Let's see what we've got here. Here's a great question from Carrie Lai. It's Arlay. It's are there any long-term problems with Ortho-K? That's a good question for you, Jackson.
Great question, Kara. So based on all the research that's come out over many decades of use, Ortho-K has been shown to be very, very safe. So the main concern that we as practitioners should be worried about is any kind of risk for microbial keratitis. And the latest research shows that it's particularly one that came out of Russia from Mark Bullimore, suggests that the rates of dangerous microbial keratitis infection rates are about the same rate as soft contact lens daily use. So that would be the most concerning risk factor. If we're talking long-term problems, a couple, in my mind, benign things that comes up in the research are you may see these iron deposits on the cornea, similar to what keratoconus patients experience. Those have been shown to be completely benign and cause no issues whatsoever. Some research has shown potentially there's some nerve density changes, which again, relatively benign, hasn't shown any kind of negative impact. So any patient, if they do Ortho-K, whether do it for 1 year or 30 years, we have patients who've been wearing Ortho-K for many, many decades. They can continue to be on, function daily. They can stop Ortho-K. It's completely reversible. They can consider pursuing any kind of refractive surgery afterwards. So if that's a question that you may want to answer from parents, you can rest assured that they can let them know that, hey, there's no issues, there's no long-term concerns with doing Ortho-K. Ultimately, it's a very safe, reversible process that will slow down their myopia, slow down their axial length, and really make them have higher chances of better vision and less chances of serious eye disease as an adult. So ultimately, I think you can practice Ortho-K very comfortably.
Great. Here's another really good question. What kind of cleaning solutions are recommended for Ortho-K? And in particular, is it any different for Euclid Max?
Great question. So there should be no difference with Euclid Max. Typically, there's a range of GP solutions you can use. As I mentioned, Boston Simplus is what your lenses will come stored in. Some patients use Boston Advanced cleaners, Boston Simplus. My personal recommendation, having seen a lot of complications over the years, is to switch to preservative-free systems. Particularly, I like the original formula triple action of ClearCare. Refined one step, that's another alternative hydrogen peroxide solution that's preservative-free. I know recently these two solutions have had more difficulties from a back ordering standpoint, whether it's due to global supply chains or whatever. But ultimately, those are still, in my mind, the best for your patients to minimize problems. And as far as fillings, insertion drops or solutions, I think a range could work. You can use thick artificial teardrop gel drops such as Refresh gel, Celluvis, Blink gel. But otherwise, I prefer to stick with preserve-free systems.
Great. Another really good question, one we get asked a lot, is what kinds of topographers does Euclid recommend are good to work with?
That's a great question. So there's no restriction. Ultimately, our staff are probably most familiar with the common ones in the US. So Medmont, any Oculus, whether it's Keratograph, Pentacam, Atlas, and I think overseas Topcon is a little bit more popular. So those are the main ones that we're most familiar with. But I know that some practitioners, they may have combo units with their autorefractors that have a topography sort of functionality. And anything you can provide is better than nothing. So ultimately, we work with any kind of company. So as long as you can provide that for a consultation team, we'll help you out as best as we can.
Excuse me. Here's another one. I think this is a really good question too. It's where does a toric Ortho-K lens fit in? Can you give your perspective on that?
Absolutely. So over the last probably 5 years or so, toric lenses have, in terms of like percentages of my Ortho-K fits, have really skyrocketed. I found that most corneas in my practice have benefited from centration and better fits. Very few corneas are actually fully spherical in nature, particularly as we approach the peripheral cornea. So I think many practitioners are likely going to see, whether you start off now or whether you talk to our consultants, once we look at the data that you provide, we'll see that more and more patients will benefit from toric lenses. So I think the statistics suggest that up to a third of patients may have corneas that would benefit from using toric Ortho-K lenses. So in terms of your fitting skill or any kind of apprehension for fitting toric lenses, just be able to assess any kind of Ortho-K lens. It's the same process ultimately, and toric is no different. But if they require it, it really will help make your patient see better. The treatment will fit better. So don't hesitate to use a toric Ortho-K design. Particularly these days, a lot of practitioners are moving towards that, as opposed to the standard spherical designs.
And Jackson, if I could just add something to that, I think that's where the consulting staff is really valuable. What you as a practitioner might be seeing for the first time, our team has seen this. They see it every day. And so I encourage you to rely on their expertise, and in particular, they can be invaluable in guiding you when a toric might help you get a better first fit success and maybe avoid an exchange down the road.
Absolutely. And just to piggyback on that, David, I just forgot to mention during the presentation, but the beauty of using Euclid is that whether you're a new practitioner, our consultation team is excellent. They'll be able to guide you through all the early stages, but as you become a more moderate to advanced fitter, Euclid has all the functionality and capability to design lenses so that you can continue to fit, medium to more advanced cases. So the consultation team is excellent. They'll be able to guide you through every step of the way. A lot of our customers just want to talk to our consultation team just because they're such great people, but the least of which is their expertise. So their expertise is world-class, so they do an excellent job. So don't hesitate to reach out to them.
So here's a question we get asked all the time, and our doctors get asked all the time. And I don't know that there's a common or a steadfast answer, but it's how long does a lens last, and what's the recommended replacement schedule for an Ortho-K lens?
Great question. So officially, any GP lens, if taken care of, technically can last quite a while. But if it's under normal use, so daily use in Ortho-K wear, I strictly recommend a 12-month replacement schedule. So this is absolutely critical because we are trying to mold the cornea basically with micron precision, right? We're making changes to the central epithelium, to the mid-peripheral epithelium, up to 5-10 microns, daily. So any kind of depositing, protein buildup, but any kind of warpage that can occur over, 365 days of use, that can impact your fitting success. So nonetheless, not the least of which is this will help you minimize your chair time in terms of dealing with troubleshooting issues that you just sometimes are not sure of. So if you have a strict 12-month replacement schedule, I think it's a safer modality for the patient, meaning maybe they'll have a better, cleaner lens. There may be less micro trauma scratches to the lenses from daily use, but also just mild changes to the curvatures will impact their ability to see. So ultimately, you'd want to have them using a proper lens replaced every 12 months, regardless of if their prescription is changing. So I tell all my parents and patients that even if your child's prescription is completely stable and we order an exact duplicate that does need to be replaced every 12 months, personally, that's my recommendation. That being said, I do know that there are practitioners who replace it on a either shorter or longer schedule. There can be reasons for that, and ultimately, every patient is different, every parent is different. So, but that would be my recommendation: is a 12-month replacement.
And Jackson, here's a question. This is actually my question. Listening to that, I mean, that's very logical. Do you recommend patients keep a spare pair or duplicate pair of lenses handy?
Yeah, that's a great question. I always recommend a spare pair. Now, the first year is difficult, so some practices may prefer to offer a spare pair plan or special pricing for a spare pair. Sometimes, let's say if there are financial constraints, I will tell parents that they can reserve a previous year's lens cleaned up and stored away in a dry, cool place as their backup. But that would only be for backup purposes until they get their official replacement lenses. So if this is the first year, I definitely would recommend getting a backup spare pair. Once you finalize the fit, obviously we don't want to order that in the beginning stages until you know the fit is proper. But once you have that proper fit, you'll save the parents and the child a lot of hassle knowing that they'll have a backup replacement.
Great. Here's a great question, I think, to close on. So we want to keep this within the hour. So what's the best way to generate referrals?
So referrals are probably one of the harder things to develop, but ultimately requires a lot of buy-in from your staff. So I always like to think of it as 100% internal marketing, 100% external marketing, meaning you can't just do one. A lot of times you already have a patient base that's already coming to your office for general primary care. So I like to think of every single patient as a potential Ortho-K patient, not necessarily a myopia management patient. So I'm always thinking of, okay, can my adult patient potentially benefit from Ortho-K? Are they pretty active? Do they do any kind of bicycling, swimming? Can my adult patients do monovision Ortho-K? So I don't try to exclude them as a group, even though this is a myopia management talk. So if you go in with the mindset that every single patient could potentially be a myopia management or Ortho-K patient, then that will really help grow your internal sort of referral base as you basically self-refer. External marketing is obviously necessary to grow any kind of practice. So that's where you'll have to do some groundwork, reach out to your local colleagues, whether they're in a commercial practice, reach out to different specialties, think about the dentists, think about the pediatricians, the orthodontists, after school programs. You really have to, first of all, educate yourself so that you know every single detail and question and answer in the back of your head. And so that when they ask you questions, they realize that you have done this, you're an expert in the field, so that they feel comfortable referring patients to your office. So again, first step is to study this, practice, set up a meeting with our practice management specialist, Christy, so that she can help you devise ideas on how to implement all these strategies. And then once you get your foundation, then you move forward to doing your internal marketing and external marketing. And again, make sure 100% of your staff have buy-in. If they don't understand what myopia management is, then the parents, they're going to talk to you. They're going to forget what you say. They're going to talk to the staff. And the staff, if they don't know how to respond to the questions, the parents will not believe or understand that this is a practice that's going to treat their patients well. So you have to make sure that your staff understand the full process. And it doesn't mean that they all need to know every single detail, but they should at least know the basic question and answers, and know that the next step is to funnel the more detailed, complicated questions to either a counselor or an ambassador that you train heavily in your practice. So those would be the best ways to grow your myopia management from scratch.
Yeah, thank Jackson. And that, I think, what just close on one comment from me. That what you just said is exactly the sort of thing that Christy Yee can help all of you that are on the meeting tonight or the webinar tonight. That is one of the things she is really expert at, and is helping you coordinate a training and a communication strategy and approach within your practice, and getting everybody on board and making sure everybody's well-versed in all of this, so that you can really capture more patients. So anyway, I guess we're approaching an hour right now. Want to try to give everybody back a minute or two. We really appreciate the fact that you took time out of your busy evening to join us. I hope that all of us hope that you walked away with some really good valuable tactics that you can implement, and look to hear from Dan and Karen over the next couple of days with the code, and they'll be helping you, if you're interested, schedule your consultation with Christy. So thank you again, and have a great evening.
Thank you.